Imagine a stone, like the size of a deer antler, just growing silently inside your kidney for years, and you never feel a single thing.
Wow. Yeah.
Right. But then imagine a stone the size of a grain of rice that causes pain so severe, doctors routinely compare it to going into labor.
And then you have to realize that if you open up a standard medical dictionary, well, both of those wildly different experiences are handed the exact same rigid ancient Greek label.
Which honestly makes you question the whole concept of medical precision. I mean, usually when we look at these massive carved-in-stone Latin and Greek terms, we assume they represent a settled map of the human body.
Oh, absolutely. We assume one word equals one specific problem.
Exactly. But for this deep dive, we are grabbing our medical dictionaries and, well, realizing that this map is full of blank spots and historical accidents.
Yeah, the vocabulary we use is often masking modern lifestyle trends, and it's standing right in the middle of fierce medical debates.
It really is.
What sounds like a perfectly precise label is frequently just a giant umbrella covering, like a dozen different clinical realities.
So our mission today is to give you a master key to reading these imposing medical terms while unpacking the surprising mechanisms hiding just beneath the surface.
Right.
We are focusing on the genitourinary system, decoding two major terms. First, nephrolithiasis, which is a stone condition, and hysterectomy, a removal surgery.
And this specific neighborhood of the body is honestly the perfect place to start.
Yeah.
Yeah, because the genitourinary system encompasses the reproductive and urinary organs. Embryologically and anatomically, they develop from shared structures and sit packed tightly together right there in the pelvis.
Which makes sense.
So by learning just a few root words today, you are going to unlock dozens of other terms across both systems.
Okay, let's unpack this. We will start on the urinary side with a suffix that basically translates to what happens when things go wrong.
Right, the classic bad news suffix.
Exactly. That suffix is a diagnose.
Yeah, that denotes a diseased or abnormal condition. You see it in words like psoriasis for the skin or, candidiasis for a yeast infection.
So breaking down nephrolithiasis, we take nephro from the Greek nephros, meaning kidney.
Yep.
We plug in lith from lithos, meaning stone, and we cap it with iosis. So literally, you're looking at abnormal condition of a kidney stone, which, sounds straightforward enough.
In a textbook, maybe. But in clinical practice, the nuance gets lost instantly, which genuinely frustrates medical students to no end.
I can imagine.
Technically, nephrolithiasis means the stone is specifically sitting inside the kidney itself.
Right.
But if it is dropped into the ureter, that's the muscular tube carrying urine down the bladder, the word changes to ureterolithiasis.
Oh, wow. Okay.
And if a clinician is just talking about stones anywhere in the urinary tract as a general category, they should use urolithiasis. But out in the real world, these terms are just thrown around interchangeably.
And that casual mixing is exactly where the trouble starts, right? Saying someone has nephrolithiasis is kind of like a car's check engine light.
That is a great way to put it.
It tells you there's a stone in the system somewhere, but it tells you absolutely nothing about the underlying chemistry, how dangerous the situation is, or, what that stone is actually made of.
Exactly. And for decades, medicine effectively treated the diagnosis exactly like that unhelpful dashboard light.
It's just a single monolithic disease.
Right. But modern stone clinics despise that approach. A stone is not just a stone.
Because the chemical building blocks are completely different from patient to patient, aren't they?
Completely different. Roughly 80% of them are composed of calcium oxalate.
Yeah.
But then you have uric acid stones, which are often tied to gout or high purine diets. You have cysteine stones, which stem from a rare genetic disorder called cystinuria, where the kidneys fail to reabsorb certain amino acids.
Oh.
And then you have struvite stones.
I want to pause on those, actually, because the struvite stones are where we get back to that deer antler I mentioned at the beginning.
Yes. The famous silent stone, clinically known as a staghorn calculus.
It sounds so intimidating.
It is. These are actually infection stones. They only form in the presence of specific bacteria, like Proteus mirabilis.
So it's not just diet, it's a bacterial thing.
Exactly. This bacteria produces an enzyme called urease, which splits the urea in your urine, making the whole environment highly alkaline.
Okay, so it changes the local chemistry.
Right, and in that specific chemistry, struvite crystallizes rapidly, forming a massive cast that literally fills the entire renal pelvis.
Just taking over the whole space.
Yeah, it branches out into the hollow spaces of the kidney, taking on the shape of a literal deer antler.
But wait, how can something that large sit inside a human organ without causing agonizing pain?
Because it isn't moving.
Oh, interesting.
Yeah, the pain receptors in this part of the body are primarily triggered by sudden stretching or distension.
Not just by something touching the inside of the kidney.
Nope. The staghorn calculus grows slowly, quietly driven by that bacterial engine, often causing no acute pain until it triggers a massive systemic infection or, completely destroys the kidney's ability to function.
That is terrifying. So contrast that with the screaming colic presentation. That is the tiny stone, the one the size of a grain of rice.
Right, that classic presentation, this sudden severe flank pain radiating down to the groin. That happens when a small stone drops out of the kidney and enters the ureter.
Because it's trying to get out.
Yes, the ureter is narrow. When the stone blocks the flow of urine, the urine backs up, and the urethral wall stretches dramatically.
So the takeaway for you listening is that the agony isn't the stone sitting in the kidney. The agony is the stone trying to escape.
Which completely shifts how you visualize the diagnosis, right?
Absolutely.
And because the specific type of stone dictates the danger and the mechanism of pain, well, researchers had to figure out how these things start forming in the first place.
Which brings us to the American pathologist Alexander Randall back in 1937.
Yes, a huge turning point.
Because medicine was trying to figure out if kidney stones were a chemistry problem or an anatomy problem, right?
Yeah.
Did they just magically materialize in the urine out of nowhere?
Right, like snow falling from a cloud. Randall sought to answer that by dissecting hundreds of kidneys during autopsies.
Dedication right there.
Truly.
Okay.
And he discovered microscopic mineral deposits on the kidney tissue itself, specifically on the renal papillae, which is where the urine empties into the kidney's collecting system.
Okay.
We now call these Randall's plaques.
It sounds a bit like a barnacle attaching to the hull of a ship. Once you have that first hard anchor point, more and more things can just stick to it.
That's a brilliant way to visualize it, yeah. Randall proved that stones don't just magically appear floating in a void.
Right.
Urine is a complex chemical solution. When it becomes supersaturated with stone-forming salts, meaning there's more solute than the liquid, can dissolve those salts crystallize.
So they find that anchor.
Exactly. They find a Randall's plaque, anchor to it like a barnacle, and then slowly grow layer by layer over months or years until they eventually break off.
Okay, let me stop you there because this is where the history gets really wild.
Oh, I know where you're going with this.
Right. If we know the barnacles and the stones themselves are mostly made of minerals like calcium,
Which 80% are?
then the obvious, intuitive solution is to tell patients to stop eating calcium.
Right.
Just starve the stone. And doctors handed out that exact advice for years.
And it was a massive, widespread failure of medical advice.
It's crazy because it sounds perfectly logical.
It does. You have a calcium stone, so cut out dietary calcium.
Hey.
But multiple prospective studies, including groundbreaking work associated with Dr. Gary Curran at Harvard using the nurses' health study cohorts, well, they revealed the exact opposite was true.
This is the part that melted my brain. The data showed that eating more dietary calcium actually lowers your risk of developing stones.
Yes.
How does that biological mechanism even work? It feels so backward.
It all comes down to where the calcium is doing its job. Think of calcium and oxalate as two puzzle pieces that just love to lock together.
Okay.
If you eat a calcium-rich diet, the calcium binds to the oxalate from your food while it is still in your digestive tract.
Before it even gets near the kidneys.
Exactly. They lock together in the gut, and your body simply excretes them as waste.
Meaning they bypass the urinary system entirely.
Precisely. But if you restrict dietary calcium, like doctors were telling people to do, you leave all that oxalate unbound in your gut.
Oh, yeah.
Your body absorbs that free oxalate into the bloodstream, filters it through the kidneys, and dumps it straight into your urine.
Where it finds whatever calcium it can.
Yep. There, the oxalate finds calcium that is naturally occurring in your urine, or even leached from your bones, anchors to a Randall's plaque, and builds a stone.
So by telling patients to skip the milk and cheese, doctors were inadvertently flooding their kidneys with unbound oxalate and fueling the very disease they were trying to stop.
Exactly. It just goes to show how dangerous intuition can be in medicine without understanding the underlying mechanism.
Wow. And we really need to understand it because the prevalence of this condition is skyrocketing, isn't it?
The epidemiological data is stunning. A landmark analysis by Dr. Charles Scales and his colleagues looked at the National Health and Nutrition Examination Survey, known as NAKEN.
What did they find?
Well, in the late 1970s, the self-reporting kidney stone prevalence in the U.S. was about 3.8%.
Okay.
By the 2007 to 2010 survey period, it had leaped to somewhere between 8.8 and 10%.
Great, it more than doubled in just 30 years.
More than doubled.
That tells us nephrolithiasis is not just some static biological glitch, it is actively reacting to how we live today.
Oh, the modern lifestyle is the perfect storm for supersaturation. We consume higher amounts of sodium and animal protein, both of which change the chemical makeup of urine to favor stone formation.
Plus the rise in metabolic issues, I assume.
Definitely. Rising obesity rates alter insulin resistance, which impacts urine acidity. Even climate change plays a documented role.
Through dehydration, I assume. Like, hotter environments mean you sweat more.
Exactly. It's called insensible fluid loss. You lose water through your skin and breath. Your kidneys try to conserve water by producing less urine, and that smaller volume of urine becomes highly concentrated.
So the salts crash out of the solution much faster.
Exactly.
The environment and our diets are clearly fueling the problem, but thankfully our engineering has evolved just as fast to treat it. I want to look at extracorporeal shockwave lithotripsy, or ESWL,
Yes.
because this technology sounds straight out of science fiction.
When a German biophysicist named Christian Chaussy first treated a patient with it in 1980, it genuinely was revolutionary. They used a device called the Dornier HM3.
And before this, dealing with a lodged stone usually meant opening up a patient's back or side with a scalpel, right?
Oh yeah, major open surgery.
But then Chaussy comes along and turns it into a procedure where you just aim focused sound waves from outside the body and blast the stone into fine sand.
It's incredible.
But explain the physics to me. If you fire a sound wave into a human body with enough force to shatter a literal rock, why doesn't it pulverize the soft kidney tissue surrounding it?
That's the genius of it. The secret is a principle called acoustic impedance.
Acoustic impedance, okay.
Sound waves travel at different speeds depending on the density of the material they are passing through. Human tissue is predominantly water.
Right, mostly water.
So the ESWL machine generates a shock wave in a water bath, and that wave travels through the patient's skin, fat, and kidney tissue almost seamlessly without releasing its energy because the density is consistent.
So it just glides right through the soft tissue like it's swimming in a pool.
Exactly, until it hits the stone.
And the stone is obviously not water.
Right, the stone is a dense, hard, crystalline lattice. That sudden drastic change in density, the difference in acoustic impedance, causes the sound wave to suddenly dump its energy.
Boom.
It creates shear forces and tiny cavitation bubbles on the surface of the stone that collapse with immense pressure, fracturing the rock into fragments small enough to pass naturally.
It is an incredible medical victory. We literally engineered a way to use physics to avoid the surgeon's knife entirely.
We did.
But that brings us to the second half of our medical dictionary journey. Because while we beat the knife with kidney stones, there are entirely different sections of the vocabulary where the knife is the defining feature.
Right.
Let's move from the iasis suffix, meaning a condition, to the iectomy suffix, meaning surgical removal.
And we are focusing on the uterus here, hysterectomy.
Let's break that down.
It breaks down into hysteri, from the Greek hystera, for uterus, and atectomy from the Greek ektome, meaning a cutting out.
Let's establish the sheer scale of this procedure, too. We aren't talking about a rare niche operation.
Not at all.
Done.
It is one of the most common major surgeries performed on women in the United States.
Really?
CDC surveillance data historically places it in the several 100,000 procedures per year. Among major gynecologic and obstetric surgeries, it is second only to cesarean sections.
That is massive.
And the primary driver isn't actually cancer, which surprises a lot of people. It is most frequently performed for benign uterine fibroids, which are benign, smooth muscle tumors that can cause severe bleeding and pain.
But just like nephrolithiasis, the word hysterectomy is a massive, highly deceptive umbrella term. Saying, I had a hysterectomy is kind of like saying, I remodeled my house.
Right, the lack of specificity in that phrase hides all the important clinical details.
Exactly. If I tell you I remodeled my house, you have no idea if I just repainted the kitchen cabinets or if I tore the entire structure down to the concrete foundation.
Right.
You also don't know if the construction crew brought their tools in through the front door or if they had to smash a giant hole in the roof to get inside.
That is a perfect analogy. In surgery, those two missing pieces of information, the anatomical extent of the removal and the surgical route taken to accomplish it well, they dictate the entire future of the patient's health.
Because the word hysterectomy by itself is dangerously ambiguous.
Very. Let's start with the extent. A total hysterectomy removes both the body of the uterus and the cervix.
The cervix being the lower neck of the uterus that connects to the vagina.
Correct. A subtotal or supracervical hysterectomy removes the upper body of the uterus, but specifically leaves that cervix intact.
Okay, so the foundation stays.
Exactly. And then you have the radical hysterectomy, which is usually reserved for cervical cancer. That involves removing the uterus, the cervix, the upper part of the vagina, and the surrounding supportive tissues, often including lymph nodes.
So a patient is often just told they're getting a hysterectomy, but whichever of those three variants they receive completely rewrites their recovery timeline, their future cancer screening needs, and even their sexual function outcomes.
Absolutely. And that only covers what the contractors removed. We still have to address how they got inside.
Right.
The evolution of the surgical route is one of the most significant shifts in modern medicine.
The front door versus the hole in the roof.
Right. For most of the 20th century, a hysterectomy almost universally meant an abdominal approach, a large incision through the abdominal wall, and a brutal 6-week recovery period.
That sounds miserable.
It was. But the late 80s and 90s saw the rise of laparoscopic approaches, and eventually robotic-assisted surgeries using platforms like the Da Vinci system.
So instead of a giant incision, the surgeon operates through a few tiny keyholes using long instruments and cameras.
Yes, and the impact on the patient is profound. Recovery time shrank from 6 weeks of restricted movement down to 1 or 2 weeks.
That's a game changer.
But again, the single word hysterectomy only describes the removal itself. It never tells you the how.
Having these incredibly nuanced, minimally invasive robotic options today is amazing. But it stands in stark contrast to the absolutely brutal origins of this surgery.
Oh, the historical record is harrowing.
How far back does it go?
Well, ancient physicians like Cyranus of Ephesus in the 2nd century wrote about removing a uterus that had prolapsed outside the body. But that wasn't true internal abdominal surgery.
Right, that's different.
The first documented vaginal hysterectomy was performed by a German surgeon, Conrad Langenbeck, in 1813.
But opening the abdomen intentionally to remove the organ early on, that was virtually a death sentence, wasn't it?
Almost always. A British surgeon named Charles Clay attempted one in 1843 and failed. The first successful abdominal hysterectomy, meaning the patient actually survived the ordeal, is generally credited to an American physician, Walter Burnham, in 1853.
Wow.
And historical accounts suggest he did it entirely by accident.
Wait, how do you accidentally remove a uterus?
Well, diagnostics in 1853 were pretty primitive. He opened the patient's abdomen believing he was going to remove a large ovarian tumor.
Okay.
Once inside, he realized the mass was actually a massive fibroid attached to the uterus. Unable to safely detach the tumor, he essentially had to improvise and remove the entire uterus just to save her.
That is terrifying, just improvising on the spot. And I assume the survival rates didn't improve much for a long time after that.
No, mortality remained above 70%, well into the mid-1800s.
70%.
Yeah. It wasn't until Joseph Lister pioneered antisepsis in the 1860s and 70s using carbolic acid to sterilize instruments and the surgical field that patients began consistently surviving the infection risk.
So for decades, the only reason doctors even attempted this surgery was out of sheer desperation.
Pure desperation. They were reacting to watching women slowly die of hemorrhage or cancer, knowing they had zero alternative options.
Which brings up a fascinating medical paradox.
What's that?
If this procedure was born out of fatal desperation, how did we reach a point in the 1990s where the medical community began loudly arguing that we were performing it too much?
It really became the defining debate of modern gynecology: overuse versus necessity. In the 1990s, researchers highlighted that hysterectomy rates in the United States were vastly higher than in comparable European nations.
The default American approach was just to remove the entire organ rather than treat the underlying condition.
Exactly. Women's health advocates raised the alarm, pointing out that hundreds of thousands of procedures performed for heavy bleeding or benign fibroids could have been managed with far less invasive methods.
What kind of alternative methods are we talking about?
Well, one major breakthrough was uterine artery embolization. Instead of cutting out the uterus, an interventional radiologist threads a tiny catheter through the blood vessels and injects microscopic particles into the uterine artery.
Okay, so those particles block the blood flow.
Exactly. They starve the fibroid of oxygen and nutrients, causing it to shrink and die, while the uterus itself survives on collateral blood flow.
That is so elegant compared to just taking the whole organ out.
It really is. You also saw a rise in endometrial ablation to stop heavy bleeding, or myomectomies, where the surgeon carefully carves the individual fibroids out of the uterine muscle, leaving the organ completely intact.
This debate completely shifted the landscape. Today, those uterine-sparing procedures are routinely offered as first-line options, especially for patients who want to preserve their fertility or simply avoid major organ removal.
Definitely.
Yeah.
And even when a hysterectomy is deemed necessary, there is an ongoing modern debate about the
The
cervix.
foundation.
Right. If the surgery isn't for cancer, should you do a total removal or a supracervical one? Advocates for leaving the cervix argue that it acts as a keystone for the pelvic floor, helping prevent organ prolapse later in life, and that it may play a role in sexual function.
But the trade-off is the residual risk of cervical cancer.
Precisely. If the cervix stays, the cancer risk stays, requiring ongoing medical vigilance.
This complexity perfectly illustrates why giant umbrella terms like hysterectomy and nephrolithiasis create such dangerous blind spots.
They really do.
They lead to major misconceptions for the patients who have to navigate them. Let's clear up a few of those myths to finish off our round.
I'd say the most persistent misconception I encounter is the belief that getting a hysterectomy throws a patient into instant surgical menopause.
Right. People assume that because you are removing a major reproductive organ, the hormone production just stops entirely.
But that misconception stems from confusing a hysterectomy with a nephrectomy.
Okay, let's use our new vocabulary skills to map that out.
We established that a hysterectomy only removes the uterus, and nephrectomy removes the ovaries.
Okay.
So if a surgeon takes the uterus to cure fibroids, but leaves the ovaries untouched, those ovaries continue functioning. They keep releasing estrogen and progesterone into the bloodstream.
So the patient no longer has a period because the uterus is gone, but they do not experience surgical menopause.
Correct. They are two entirely distinct anatomical procedures.
Got it. Another massive myth that puts people in danger. I had a hysterectomy, so I never need to get a pap smear ever again.
Oh, this one is huge. And it circles right back to the specific type of surgery. If you underwent a total hysterectomy for a benign condition, the cervix was removed.
All right.
In that scenario, routine cervical cancer screening usually stops. But if you had a supracervical hysterectomy, meaning the contractor left the foundation in place, you still possess a cervix.
So you absolutely still require routine pap smears.
Yes, 100%.
Yes.
This is why decoding this medical dictionary is so empowering for you as a listener. Once you understand the root components, you can read the entire map of the human body. We know nephro means kidney, hyster means uterus, iasis is a condition, and electomy is surgical removal.
So if you come across the word nephrectomy,
You instantly know that means surgically cutting out a kidney.
right, and if you recall that lith means stone, and you learn the Greek root tripsosis translates to a rubbing or crushing.
You get lithotripsy, the sound wave technology using acoustic impedance to crush kidney stones.
Exactly.
And if you start stacking prefixes like salpingo for the fallopian tubes and ufro for the ovaries, you end up with the absolute tongue twister salpingo oophorectomy, which simply means removing the tubes and ovaries. It is literally like snapping Lego blocks together.
It really takes the intimidation out of the medical chart.
So to summarize our journey today, we've learned that a stone is never just a stone. It could be a silent staghorn driven by bacterial enzymes or a screaming colic triggered by calcium binding in the gut. And a hysterectomy is never just a standard surgery. It is a highly complex decision about anatomical extent and surgical route that evolved from a deadly historical last resort into a nuanced, minimally invasive procedure.
These terms are so much more than dry vocabulary. They are gateways that help us understand our changing modern diets, the brutal history of surgical survival, and the incredibly complex machinery of our own bodies.
Absolutely.
If we bring this all back to where we started staring at that rigid ancient medical dictionary, I want to leave you with one final thought to mull over.
Lay it on us.
As medical technology continues its rapid advance, well, as we engineer invisible sound waves to shatter stones and deploy remote-controlled surgical robots to navigate blood vessels with microscopic precision, we have to wonder, will these broad, ancient Greek umbrella terms eventually become completely obsolete?
Wow, that is a profound question.
I mean, as our treatments become hyper-specific to your exact chemical makeup, your genetics, and your unique anatomical needs, the medical vocabulary of the future might no longer describe the whole organ we are treating. It might only describe the microscopic building blocks where the disease actually begins.
The dictionary isn't set in stone. It is still being written every single day. Thank you so much for joining us on this deep dive. Keep asking questions, keep looking past the umbrella terms, and stay curious. We'll catch you next time.